Good day, friends of Buzzy. Welcome to the 6th of January, aka the day that Georgia seems to really be staying blue. Today, though, we're going to talk about the COVID vaccination drama that's all over the news about the slow rollout, what's happening, how you get in line, who's jumping ahead in line, and how pediatric solutions can actually be the savior for all of the vaccination problems as we get to herd immunity. First, I want to say that there is this misconception, which is guided by several articles that were allowing people to calculate where they are in line for vaccination, that imply falsely that there is one line. One of the issues with distributing things to a lot of people at once is that the mathematics of rapid distribution mandate that you need to have not one line, but multiple lines. Even within a state or a hospital, you're not going to have one line because you're going to have different places where vaccines are administered. Why, one of my good friends asked, are we so slow in Georgia with our vaccine rollout? The issue is that vaccinating large numbers of people requires a sophisticated logistical exercise that, like anything else, gets better with practice. Currently in Georgia, the places that are designated as early Moderna, Pfizer vaccine distributors are public health departments. The problem is that while public health departments are used to giving vaccines, they are not used to the kind of wham, bam, go back to work, ma'am, that hospitals are. Because every year in hospitals, flu shots are given en masse to every single person over the course of a couple of days. You stand in line, you get your shot, you go back to work. They come around with a cart, you get your shot, you go back to work. Currently, certainly in Alabama, in California, hospitals are overwhelmed with COVID patients and they can't take on this degree of logistical responsibility. This is where I think pediatric solutions can come in. You know, I've been talking about Buzzy being the solution for getting people to take their second shots and to not have fear or pain. And it turns out to not even have the soreness the second day if you tenderize the muscle before you get your shot. But that's not what I'm talking about. Pediatric hospitals are not slammed right now. Flu is low. Other viruses that usually circulate in January are minimal because schools are closed and because people are masking and doing everything else for COVID. Why not have pediatric hospitals be the main distribution centers for the elderly and the patients who should be at the front of the line from a risk standpoint, but are mobile enough to go and get it? We've heard stories of seniors 75 and up waiting in line in Tennessee, only to be told there wasn't enough vaccine, only to have people where the vaccines were being given out call their buddies later because they had extra ones that were thawed and ready to go. There are places where only hospital-affiliated pediatricians can get in line for their vaccines because it's almost like the banking issue with the PPP. If you have a banker, then it was easy to get the forms and to get in and get your loan. If you didn't have one, then trying to figure it out independently was an enormous amount of time. I think it's analogous right now. We have a place in just about every large city, some have two, that is very accustomed to giving mass vaccinations, but doesn't have a lot of volume right now. Children's hospitals could give back to the community by providing an easy access extra line that ambulatory seniors, pediatricians, or other doctors in the community who are general practice doctors who need to have a fast, easy way to go can get their vaccines while still having the mandatory cold, safety, everything else that a normal children's hospital takes for granted. Employee health does this in their sleep. Why can't we have the children's hospitals step up and take over vaccinating for community physicians and healthcare workers and for people who are over the age of 60 who don't have a place to get their vaccine easily and don't want to overburden the public health offices that are not used to this kind of lines out the door, get them all done, rapid fire. So that's my two pediatric solutions for the current vaccine crisis. I don't really think we're having a distribution crisis, though. I think that this is something that once it gets rolled out, it will be much smoother than it looks right now. It's always more difficult to establish systems than it is to maintain a system. Once you've created a system, once you have people who are providing a service in a regular way, then it's much easier to push things through. But building that assembly line, yeah, that looks a little awkward. That's where we are right now. But I do think that we are going to get enormous numbers of vaccines rolled out very, very quickly. That's a good thing, because the different variants that are spreading right now, what do we really need to worry about in terms of the COVID variants? A couple things can mitigate the worries about the B117 UK strain. That strain is between 10 and 70% more virulent, meaning that more people catch it. The virus is infecting more people, but thus far it doesn't seem to cause worse disease. The disease we got is bad enough. One question last week was, how do you stop having the lung effects of coronavirus? And what do you do for COVID-19 to decrease the likelihood of getting severe illness? Paper came out in October that noted that the likely way that the SARS-CoV-2 virus is extending into the pulmonary system is not from breathing it in. It's probably that when you snore or when you speak, you inhale tiny micro bits of virus from your nasopharynx. So we know that the virus goes in primarily and replicates in the nasopharynx. And so then for people that have more obstructive sleep apnea, regardless of whether they're obese or not, they get worse lung disease. So these guys in October figured out what the amount is that people of different ages and sizes aspirate, which means breathe in every day, and hypothesized that the timing works, the viral load works, the amount and frequency of viral particles that you are breathing in from your own nose, that intense collection of viral load on the droplets that your own nose makes, that's why you get it spreading to your lungs. So again, nasal irrigation makes a lot of sense to decrease the volume of the virus so that less of it is likely to go in. Also, there'd been a debate early on, do you keep using CPAP if you're on it? The concern was aerosolizing particles and spreading them to other people. But for the first 7 days after you have symptoms, you are contagious. And 2 days before, but the 7 days after you are contagious, you don't want to be having somebody else in the room with you anyway. So to decrease the likelihood that you're going to aspirate viral particles and infect your own lungs, keep using the CPAP. If you have obstructive sleep apnea and you're on it, you will inhale less of your own viral particles. All right, so that little quick answer for the last week's question. But what does that have to do with the different strains? Well, what it has to do with them is that in order to get to a herd immunity state, it depends on how contagious the virus is. Measles are super contagious. They have an average of 17 people that one person infects. So if you've got a crowd of people who are not immune to measles, each one person who has the virus, it's so contagious, they're likely to spread it to 17 other people. That number is the R naught for various reasons. But so R naught for measles is like 17. The R naught for SARS-CoV-2 has been debated, and it is interesting because it's actually changed the way epidemiologists look at the transmissibility, because the R naught is felt to be a range, but it seems like it's related to the virus itself. What we're finding with SARS-CoV-2 is that the transmissibility is highly related to the season. It's related to the humidity. It's related to air temperature. So there are a lot of aspects of the SARS-CoV-2 virus that have variability in the transmission rate that are not is changing depending on season and also depending on what the aspects of the person are. We know that super spreaders are more likely to be older, male, and overweight. This is because if they are male and older, they've got bigger nasal cavities that have more virus. And if they're overweight, they are speaking more forcefully and more particles are going out. So the R naught is not just about the virus itself, it's about the environment. That said, if the transmissibility of the virus itself goes up, then so does everything else. So that's why we're concerned about this B117, is because if it is actually easier to catch, we have to have more people vaccinated to be able to keep the herd safe. Now, the South Africa one is a little bit more concerning because the implications are that the spike protein on the SARS-CoV-2 molecule are changed enough that the current vaccines that we're using may not be as effective. So this is why it's really important to get to herd immunity as soon as possible, because these strains in and of themselves may not be that big a deal from an illness standpoint, but they're certainly a big deal in terms of our virus. Now, in terms of the spread and sickness and the vaccine. One of the things that typically happens with viruses is that over time they mutate to become less severe. The reason is if you mutate to cause worse disease, then you kill the people who are carrying the disease and you don't spread. A successful strategy for a virus is to become just bad enough to let people still be walking around and spreading it, but not so bad that you kill somebody. Therefore, the likelihood is that we will have this virus with us. We will need a vaccine every year. And just like the flu, we're likely to have to do a slightly different strain each year. In sum, yes, I'm worried more about the African variant in that, or the South African variant in that it has the potential of spreading now and invalidating what's going on with the vaccination. However, the more important thing is if we can get vaccinated quickly before the more virulent form is around, then stamping it down with the vaccines may buy us the time to not even really need to worry so much about the small amount of the South African variant that's in the population. Overall, though, it's not a cause for drastic gnashing of teeth and being afraid, because we can make vaccines modified. The most recent thing I read said that about 4 to 6 weeks would be required to match a new vaccine to the new spike protein if necessary. So the approval process would be dramatically spread. It would be kind of like the flu vaccine where it's just redone every year and its manufacturing process is so well known that you don't have to go through a new approval each time. So I don't think this is going to be the end of civilization, and I don't think that we're going to be still having the same lockdown mentality in 6 months, regardless of how far either of those two variants spread. But we do need to get vaccinated now as fast as possible, and if you get vaccinated with a buzzy to decrease the soreness the next day, to make people more comfortable and less afraid so that they're more likely to get that second vaccine, which is the one that really cements the immunity. And if we get our children's hospitals to come to the rescue, fly in and be the super providers for the community that can't be easily and efficiently seen in the public health departments, that could solve our problem. Please look at our other videos about herd immunity, about the number of people who are impacted by fear, fainting, pain, etc. And I will keep seeing you on a weekly basis until this pandemic crisis is a historical rather than an ongoing source of stress. It's going to be fine.